Hello, and welcome to the Sarcoma Foundation of America's education session discussion of ctDNA live with the experts. This will be the first introductory session in what will be an ongoing series of education sessions focused on pediatric sarcomas. My name is Dean Freilich, and I'm the Director of Scientific Affairs at SFA, and I will be serving as your host and moderator for this panel discussion. We thank you for taking the time to join us for this important conversation. Before we begin, I will briefly go over the format and logistical details of this webinar. Joining me are three panelists who are experts in the care of people with sarcoma from sarcoma centers here in the United States and abroad. These experts will share information to help you understand the basics of ctDNA, how it is being used in oncology, and the state of the field in sarcoma. At any time during today's session, you can submit your questions by entering them in the Q&A field at the bottom of your screen. I will then share your questions with our panelists. Please do not use the chat function to submit your questions. Questions submitted in the chat box will not be addressed. Please remember our panelists will not be able to answer your questions related to your specific medical situation. Information in this webinar is for educational and informational purposes only, and is not a substitute for medical advice from your physician or care team. Today's session is being recorded, and a link will be distributed to all registrants and posted to SFA's website. Finally, as a reminder, all participants are muted, but we encourage you to participate by submitting your questions in the Q&A box at the bottom of your screen. Now I'd like to briefly introduce our panel members. Dr. Choy is the Director of Sarcoma Research at the Division of Hematology Oncology at Massachusetts General Hospital. He specializes in the medical management of patients with sarcomas, gastrointestinal stromal tumors, chordomas, and desmoid tumors. He directs a clinical trials program at the MGH Center for Sarcoma and Connective Tissue Oncology that includes multiple active phase 1 through phase 3 clinical trials. He also maintains an active scientific research program that investigates areas of sarcoma therapy ranging from the use of nanotechnology and other translational research tools aimed at developing new targeted therapies for treating cancers to preclinical studies using cell lines and animal models to better understand the molecular basis of sarcoma biology. Dr. Schulman cares for patients at Dana-Farber Boston Children's Cancer and Blood Disorders Center and is an assistant professor of pediatrics at Harvard Medical School. He studies novel therapies and biomarkers for patients with advanced sarcomas at the Dana-Farber Experimental Therapeutics Program. In addition to caring for patients with sarcomas and leading early phase clinical trials, Dr. Schulman co-leads an effort to evaluate ctDNA as a potential tool to improve the ways in which we treat patients with bone and soft tissue sarcomas. Dr. Loong holds conjoint appointments of Clinical Associate Professor in the Department of Clinical Oncology and Deputy Medical Director of the Phase 1 Clinical Trial Center of the Chinese University of Hong Kong. His clinical and research interests include thoracic oncology, sarcoma medical oncology, and health economics. Dr. Loong has co-founded the Asia Pacific Oncology Drug Development Consortium and the Asia Pacific Coalition Against Lung Cancer. He was elected as a board member of the Connective Tissue Oncology Society for 2022 through 2024. Thank you all for being a part of this discussion. I'd like to hand it off to Dr. Schulman to get us started.
All right, well, thank you so much. I'd first really like to extend a huge thanks to SFA for the opportunity to join this morning. And I feel really excited to join with Dr. Loong and Dr. Choy for our discussion of circulating tumor DNA in sarcomas. I appreciate giving the introduction to myself as well. As you heard, I'm a pediatric oncologist by training with a focus on adolescent and young adult sarcomas, and do clinical research focused on new trials and use of circulating tumor DNA in patients with sarcomas. This morning, my goal is to really provide an overview of how I think about circulating tumor DNA and liquid biopsy for patients with sarcomas. And this is really a framework for how I think about these assays if I'm in clinic and I have a patient who asks me about them and how they might help inform us about their clinical care, and about how I think about using this technology for new research studies and how we can better understand disease. So first of all, what is circulating tumor DNA and what are liquid biopsies? So circulating tumor DNA is a type of liquid biopsy, and liquid biopsy is really a means of assessing features of a tumor, whether that's a sarcoma or another cancer, in some kind of bodily fluid, such as blood or urine or cerebral spinal fluid or what we would call spinal fluid. For patients with sarcomas, we're usually talking about doing this in blood. So from a blood sample that you would draw, like when you were otherwise having labs. Circulating tumor DNA is one of many elements of a tumor that we can measure in the blood. And so on the right is a figure from a really wonderful review article that I recommend checking out if you're interested in kind of diving more into the weeds of this technology, from Nature in 2018. The first author is Dr. Wan. And we think that circulating tumor DNA, which are little double-stranded bits of DNA that float around in our blood, come out of tumor cells when the tumor cells either undergo regulated cell death, which we call apoptosis, or whether they undergo sort of unregulated cell death called necrosis, or actively excreted or secreted by the tumor cells. In point of fact, in the blood, I'm actually not sure if everyone can see my mouse, but I'm going to move my mouse over the screen, and hopefully you can see the pointer. Um, and there's many different features of tumor cells that float around in the blood. So there can be circulating tumor DNA, but there also can be apoptotic bodies, extrachromosomal DNA. Sometimes people talk about RNA, and all of these things can be measured, but really of the different sort of liquid biopsy technologies, circulating tumor DNA is by far the best studied. So how do we actually measure circulating tumor DNA and what are the okay, I think you can't see my pointer, but maybe if I do this, it will be visible. I'll talk through it just in case you can't see it. So um, uh, on the left-hand side here, you can see what would be a blood vessel between the yellow lines. And for a patient who has cancer, there are tumor cells in this blue cell in the upper left. And there may be normal cells, like the cells that line our blood vessels or white blood cells. And both of these cells, as they turn over and die, release DNA into the blood. So in everybody's blood, they'll have normal DNA that floats around. And in a patient who has cancer, there may also be DNA from the tumor. And so we can collect this in a blood sample. The blood sample we would process by spinning down and isolating the plasma, which is sort of the clear part of the blood after we've removed all of the blood cells. And then we can go ahead and um, extract the DNA from that blood sample and use conventional sequencing technologies to try and find elements of DNA from the tumor cell. So in this case, it would be the sort of red DNA. And you need some means of differentiating this tumor DNA from all of the normal DNA that floats around in the blood. So one sort of common way that we might do that is looking for what we call copy number changes, or sequencing the whole genome and looking for parts of the chromosomes or genes that have been duplicated or deleted. I think there was already a question in the chat about EWSR1 fusions, which are one particular kind of gene fusion that we see in sarcomas. And so you could set your assay up so you're trying really hard to find that particular fusion. If you know what diagnosis the patient has. And then there's multiple other ways that we can try and identify what are the elements of the tumor DNA that are different from the regular DNA in a person. Some of those other things that you might hear about are methylation profiling or PCR-based assays. And then we can analyze that sequencing data and look at, for example, um, all of the copy number changes and use an algorithm to say, okay, how much of the DNA that's floating around is coming from the tumor cell? Is it 1%? Is it 5%? Is it 20%? We can look specifically at the fusion and say, okay, how many of the fusion genes are we seeing and how many of the regular copies of those genes are we seeing? Is it 3% fusion? Is it 0.5%? And then we can look for particular gene mutations that might make us a little bit smarter about that tumor. Sort of the most commonly mutated gene in cancer is TP53. So maybe you see that 10% of the DNA floating around in the blood has a TP53 mutation, or you can look at a copy number change, such as MYC amplification. And we know a little bit about how likely we are to find circulating tumor DNA in patients with sarcomas, but I think as you'll hear from the other presenters, we have a long way to go in terms of really understanding how to use this technology. So I didn't include a whole lot of data in my sort of 10-minute overview today, but I thought I would include a little bit of data from an old study that we published back in 2018. Where we looked at a cohort of patients who had been treated for localized osteosarcoma. So that means the osteosarcoma, bone sarcoma that was just in one place when they were diagnosed. So this was a group of 72 patients, mostly teenagers who had submitted blood samples on some older clinical trials and clinical research studies before they started any treatment. And so we used some relatively straightforward sequencing assays to look at those copy number changes in that we see commonly in osteosarcoma. And we first asked a very simple question. So if we use these tests for patients who have not had treatment yet, have a tumor, how likely are we to find circulating tumor DNA and be able to quantify it? And it turned out for that population of patients, in 57% of patients, there was more than 3% tumor DNA floating around in the blood, which was the lower limit of detection of this particular assay. And then in the rest of patients, we actually weren't able to identify tumor DNA. Doesn't mean it wasn't there, it probably was there, but at a lower level than our tests could really quantify. And so with sort of conventional next generation sequencing assays that we would use in the research laboratory and that you might see out there as commercial tests, it turns out for the cohorts of patients that we've looked at here at Dana-Farber with localized sarcomas, actually this is pretty similar to sort of what we would typically see. We're in the range of like 60 to 70% of patients we can identify tumor DNA, but in many patients actually we can't identify it yet. And so how do we think about sort of systematically studying this? And you know, one of the sort of questions you can ask is, how can we make our assays better? And there's a number of new exciting assays that you may see out there, such as Natera's Signatera assay, Saga Diagnostics. There's research assays where they're doing this. But can you find more sensitive ways so that you can find circulating tumor DNA in a higher percentage of patients when they're diagnosed, and then continue to identify it, for example, after patients have treatment, when they have a very low burden of disease? And so you can imagine one of the challenges with any of these tests is if you have like a single feature in the DNA that you're looking for in the blood, and then you have tons of normal DNA floating around in the blood, you know, at the time point before the cancer cells have really started to grow, or when there's very, very few cancer cells in the body, the vast majority of the DNA you're going to see in a blood sample is just coming from normal cells. And then as tumors start to grow a little bit, there may be one or two strands of tumor DNA floating around in the blood. But if you're only looking for a single feature, you could easily miss it. And so one of the ways to really increase the sensitivity is say, I'm going to look at multiple different features of that tumor cell. So if feature A happens to not get picked up in that blood sample, but feature B does or feature C does, you have a much better chance of actually identifying and quantifying circulating tumor DNA. And so as disease burden gets higher, you have a better chance of picking it up with sort of more conventional tests, but in very low-level disease states, you may need something that's much more sensitive. And so as these assays get developed, we want to ask specific clinical questions. And so one of the first questions we asked in our study of circulating tumor DNA for patients with osteosarcoma, and sort of the other half of my research is in Ewing sarcoma, was the very fundamental question that if when you're diagnosed with a bone sarcoma and you have high circulating tumor DNA when you walk in the door on day one when you're diagnosed, does that tell us something about how likely treatment is to work for you or not work? And so using that old cohort I looked at, and then a newer study that was presented over the last couple of years at a couple of conferences, we looked at patients who had high circulating tumor DNA, compared to low circulating tumor DNA. You'll have to pardon me. I've lost my slide advance button. There we go. And what we found was that patients who had high circulating tumor DNA shown in this Kaplan-Meier plot in the back, on the right, were more likely to have their tumors come back after treatment than patients with low circulating tumor DNA. And so you can walk through the care continuum and ask a lot of different questions. So at time of diagnosis, we can ask that question, does it tell us something about prognosis and how likely tumors are to come back? Can we look at minimal residual disease after patients have had surgery or radiation or chemotherapy and does that tell us something about how well the treatments worked? We can look at it at local control. During surveillance, we can look and see, can these assays tell us on the early side when a tumor is coming back so that maybe we can intervene earlier and have more effective relapse treatments? And then at time of relapse, could they maybe make us smarter about using targeted therapies? And as you think through each of these questions, it's really important to think about what test you're using. So in the yellow here, you can imagine that the amount of circulating tumor DNA in the blood goes down dramatically after we do surgery or give radiation or do chemotherapy. And actually, for most patients, it's going to drop below the level of what our most sensitive, or of what our sort of traditional tests can do. But maybe our more sensitive MRD tests can actually detect circulating tumor DNA at those times. When tumors come back, we may be able to use those less sensitive tests and find lots of information about the biology of the tumors and potential use of targeted therapies. And then we may need to use those more sensitive tests to kind of track low-level disease. So there's a lot of different considerations anytime you're thinking about studying circulating tumor DNA or using circulating tumor DNA. I've tried to give you like a crash course here in a relatively complicated technology that we're just learning how to use. But I think it'll feel a little bit more clear as my co-presenters tell you a little bit more about how it's being used in other cancers and sarcomas. So thank you.
Right. Thanks, Dr. Schulman, for giving a very good introduction to circulating tumor DNA. And just like Dr. Schulman, I just want to thank SFA for giving me this opportunity to join this webinar. Good morning, everyone. Good afternoon, good evening, wherever you are. I'm Dr. Herbert Loong from the Chinese University of Hong Kong. To me, it's 10:19 p.m. Here in Hong Kong. So after this, I get to go to bed, which is great. My task really is to talk about how ctDNA is currently being used in other cancers. And my colleague, Dr. Choy, will then also be speaking on how specifically it's potentially being used in sarcomas or where the future is for sarcomas. So let me grab control. Let's see. I have the pointer, but let's see. Okay. All right, so in terms of the potential roles for utilizing ctDNA, and I would take a relatively broad stroke thinking about the entire oncology spectrum. So we're not just specifically in sarcomas, but in all oncological conditions. I guess we can actually filter it down and say where ctDNA can be useful. To begin with, in helping make a diagnosis, especially in situations where, say, a tissue diagnosis is inadequate or not possible. It's very useful in the monitoring of treatment response, especially if we are using specific targeted therapies where we are able to track the allele frequency or the mutations that's present after treatment in the circulating tumor DNA. And of course, in situations where there is potential treatment resistance, for example, or even identification of possible resistant mechanisms when it comes to treating patients with, say, various targeted therapies or other types of therapies. And in terms of the hypothetical advantages of using ctDNA, I think one of the biggest sort of advantages of using this technology is the fact that it is dynamic. So you're able to track a patient's treatment journey throughout the time course of the patient going through treatment. And with that in mind, it is in general, to begin with, easy to obtain, especially when we're talking, for example, like a blood draw. Of course, we could potentially use other biofluids as well, but I think specifically for this discussion, we'll be talking about blood. But again, the great thing is you're able to do it dynamically versus, trying to obtain the same information. If you are doing a tissue biopsy, a repeated tissue biopsy can be somewhat cumbersome. It can be relatively invasive. There are also potential risks with that particular situation. And I think the other aspect about ctDNA is, in general, if it is of a good sensitivity, you are able to detect the diversity of the various clones within the circulation. So you get a more holistic picture, especially in situations where a patient has had some sort of treatment and you're developing various potential resistant pathways. And in general, as Dr. Schulman has already discussed, we can consider using ctDNA to identify and monitor for minimal residual disease in situations where, for example, radiologically, if you do a CT scan or an MRI, you may not be able to pick it up, but the presence of various or amounts of ctDNA can give you a preclinical situation or detection of potential treatment resistance. And of course, in situations where you're able to actually monitor the disease, even radiologically, again, the great thing about using ctDNA is it can be done dynamically, serially, and it is actually a quantitative method of monitoring what is also apparent disease as well. And so I think what I have decided to do is really to provide you with some examples on the different cancers of which ctDNA is now either being used in clinical practice, or certainly there's a lot of research that's going on to validate some of the clinical trials of those particular disease or tumor types. So to begin with, I think non-small cell lung cancer is definitely one of these disease types where ctDNA is really now already in the mainstream when we think about helping to make diagnosis, detection of treatment resistance, or to help us guide treatment. This is essentially a graph indicating where ctDNA can help make various treatment decisions or monitoring decisions. So in this example, for example, this is a patient with an EGFR mutation in their tumor. And certainly for us, especially in Asia, this accounts for about 40 to 50% of our non-small cell lung cancer. So certainly by doing a blood draw, for example, you're potentially already able to diagnose the presence of having EGFR mutations in the ctDNA in the blood, and therefore helping to make the diagnosis and be able to channel patients to appropriate targeted therapies. So for example, here using osimertinib, which is our typical first-line treatment in these patients. Now, there are situations where the ctDNA can also be dynamically changed. Say, after surgery, you may have an undetectable amount of ctDNA, and that allows us to give us an extra way of monitoring for whether or not the patient may or may not recur in terms of their disease, or in the situations where there may be evidence of, say, minimal residual disease, where radiologically, if you do a CT or an MRI, you cannot see the presence of this potential recurrence, but be able to detect it early. You can then actually change your treatment strategy. You might want to give treatment before the patient actually has developed a clinical relapse, and then therefore preventing that from happening. It also helps you guide whether or not there's a need for, say, adjuvant treatment after a definitive, say, surgery or definitive treatment. So it does give you a lot of various, helps you make various treatment decisions throughout the patient's treatment journey. Now, another example would be in breast cancer, and again, very similar concept where, for example, say initially after surgery, there could be a drop in the ctDNA, but at the same time though, we know that, for example, in patients with hormonal positive breast cancer, after treatment with, say, aromatase inhibitors or other adjuvant treatments, they may develop various resistant mechanisms. And again, using the ctDNA, you may be able to detect these resistant mechanisms and be able to intervene early by giving other types of treatments, which could prevent, again, a clinical relapse or a clinical recurrence. Now, another potential example, and this is illustrated in colorectal cancer, is the use of ctDNA can help us make treatment decisions, not only to, say, increase the need for treatment, but also to potentially what we call de-escalate treatment, where, for example, it can give us an inkling of, oh, well, there isn't the presence of a detectable ctDNA, so in actual fact, the chance of the disease worsening or the chance of disease relapse is relatively low. And in these situations, for example, we can probably avoid giving treatment to some patients. And of course, that means that you could reduce the potential side effects or the toxicities for patients who really didn't actually need that adjuvant treatment. So I think, again, aside from monitoring of a patient throughout the treatment journey, it also helps us make decisions as to whether or not they need treatment, and a potential de-escalation can actually be very beneficial as well. And I just want to highlight one recent example of how ctDNA has been embedded into a clinical trial, really then helping to hone in and harness the value of ctDNA in terms of making treatment decisions. And this was actually a very interesting oral abstract that was presented at the recent ESMO meeting by Dr. Tom Powles in bladder cancer. And this is a trial known as IMvigor011, where essentially patients who have high risk invasive bladder cancer after treatment was then tested for ctDNA in their blood every 6 weeks. And in patients who are consistently negative, there was no need for any adjuvant treatment. But in patients with ctDNA that was detected to be positive, in actual fact, the patients were then randomized to either receive an adjuvant immunotherapy known as atezolizumab, or potentially the use of a placebo. And the primary endpoint of this trial was to look at disease-free survival in patients who were ctDNA positive, also to look at the overall survival of the patients within this particular trial. So I appreciate the fact that this is not a bladder cancer audience, and certainly this is just an example, but really just to highlight the fact that using ctDNA, they were able to identify the fact that if it was negative after the initial treatment, the patients actually had a very good disease-free survival and a low risk of death. And this is shown here in the survival curve on the left-hand side. And on the right-hand side are the patients who had detectable ctDNA, where they were randomized to either receive the adjuvant immunotherapy or placebo. And what you can see on these two survival curves really is the fact that the blue line are the patients who actually received the adjuvant immunotherapy. They actually had a better disease-free survival as well as a better overall survival. And essentially, we were able to tease out who the patients would benefit most from in terms of using immunotherapy. And by using this particular technology, having this particular framework to try to detect the presence or absence of ctDNA after surgery, you are then able to essentially pick out the patients who really need this treatment, so therefore avoiding this toxicity for patients who don't need it, and then to be able to improve the survival outcomes as well. And this is just a demonstration of how we can actually use ctDNA in our clinical practice. And in actual fact, it's through these clinical trials that helps us validate the value of using ctDNA. So I think what we potentially may need for sarcoma, for example, and I believe Dr. Choy may be talking about this a bit later, is how we could potentially embed this technology in some of the evidence-generating trials that we're doing, and then to be able to see whether or not we could put ctDNA into the mainstream for sarcomas. So just to end by saying the fact that Dr. Schulman's already mentioned this, although we commonly talk about ctDNA and blood being the fluid that we use for detection, there are other various biofluids that's potentially available in the body. And those are actually also actively investigated to help us detect ctDNA. So watch this space. I think we're going to see a lot of emerging interesting technology and potential applications of ctDNA, again, in sarcomas as well as in other cancers. And I think with this, I would pass the baton over to Dr. Choy.
Thank you, Herbert. So my part is to sort of take everything that Dr. Schulman and Dr. Loong talked about and sort of narrow that lens into sarcoma. Can I have control of the slides, please? Okay, so start with some disclosures. So these are various companies that I either consult for or support my clinical trials. Just want to hone in on these four companies at the bottom: Foundation, Tempest, Garden, and Natera. These are not companies that I've done any consulting for, but I still list them in today's disclosure only because I use them quite a lot. And so there are at least 5 other companies outside of these that also do excellent ctDNA testing. And so I just want to say I don't have a preference for any one or the other right now. These are just 4 that I happen to work with, but that doesn't mean that they're either better or worse than anyone else. And so we heard about how ctDNA can be helpful. And so how do we use it in the actual care of the patient with sarcoma? Let's start with some disclaimers. So first of all, the data right now that actually supports using ctDNA in sarcoma is actually quite sparse and anecdotal. And so we need much more research in order to establish a clear role for ctDNA in patients with sarcoma. And so everything we're talking about today are topics that we find tantalizing, and they're exciting areas of further investigation. But none of this should be considered established fact or truth or science. And so in my field, we call this hypothesis generating, right? So if there's an exciting idea, at this point, it's a hypothesis that we want to test in either a laboratory or clinical trial setting. Before we know that it's actually beneficial in this population. And so the actual benefits for ctDNA in your individual case should always be discussed with your own team of sarcoma doctors. So we can't make a recommendation about ctDNA in a vacuum or in the absence of your specific clinical situation or what your surgeon wants, what your radiation doctor wants. And then keep in mind, any test, no matter how fancy or cutting edge, when we use it incorrectly, it can be misleading and lead to additional testing or treatment that can actually be harmful. And so, so at the end of today's webinar, let's just be sure that we situate all of our findings in the right clinical situation. All right, having said that, so how can ctDNA be used in the care of the patient with sarcoma? Well, we've talked about 2 of these 3, right? So Dr. Loong and Dr. Schulman talked about how it can be useful in monitoring and prediction of disease. I'll talk a little bit more about how we can use the actual mutation seen in ctDNA to actually guide therapy. And then one topic I think we didn't really talk so much today is early detection of new cancers or new sarcomas in a healthy patient who doesn't have a sarcoma. And so for monitoring predicting, earlier today we talked about minimum residual disease, which we often refer to as MRD testing. So after the tumor is removed, when scans don't show any disease, there's a question of whether or not more treatment or chemotherapy, which we call adjuvant chemotherapy, can be helpful to eliminate microscopic disease. And then we also want to use ctDNA to predict for risk of relapse. And as Dr. Loong mentioned, the higher the risk, the higher the benefit of more treatment. And so if we're offering more treatment in the absence of unmeasurable disease, we really want to focus in those treatments in a patient population that has the highest risk of relapse, because those are the people who will benefit most from this type of testing. And then we can also use ctDNA to track response to treatment when scans are not good enough. And Dr. Schulman gave a really nice introduction to how we can do that. So in terms of guiding therapy, we also want to use ctDNA to help one day make surgical decisions. So for example, if a patient has metastatic disease and they're responding really nicely to chemotherapy, there's always a question of how much more chemotherapy do we need? At what point do we want to turn to surgery to remove whatever disease we have left behind? At the end of a course of chemotherapy, if there are some lesions left behind, is it best to just keep an eye on those lesions and watch closely? Or do we want to do surgery to remove the metastasis? We call that metastatectomy. And then the timing of when to do this surgery, earlier, later, or never. And so in terms of treatment duration, often right now in the absence of ctDNA, I tend to continue chemotherapy in the setting of metastatic disease for as long as possible. But there is such a thing as having a maximum response. And so ctDNAs might be able to shed more light on whether you get a maximal response with no circulating DNA, no evidence of any DNA from the tumor, or if we have maximum response, but still with shedding circulating DNA. And that might change how much chemotherapy we want to give. And then in terms of tailoring therapy, sometimes we try to treat sarcomas based on which gene is mutated. And so that could sometimes change over time. And so circulating DNA can be very helpful in deciding which mutation to target. And so a quick word about early detection of new cancers. It's very tantalizing. One commercial option is the Galleri test, or known as the GRAIL test. And it's really for patients who do not have a diagnosis of cancer. And this test can detect more than 50 different types of cancer. It's not FDA approved yet, and so insurance usually does not compensate for this testing, and you'd have to pay about $1,000 out of pocket for this. Right now, there's a trial being done in the United Kingdom called the NHS Galleri trial, and it looks to see if this test can be helpful when performed in conjunction with standard cancer screening methods to help find and treat cancers even earlier than you can with normal screening. And so their goal is to test about 140,000 people with no history of cancer. And everyone in the trial will have 3 blood tests over 2 years. And then of those patients, they'll have half the participants actually test for the Galleri, and then the other half of the participants not test for the Galleri, and see if testing for Galleri will actually improve survival, cure rates, diagnosis, and other benefits. So in 2021, the Galleri test had a validation study, which included 2,800 people who had known cancer and 1,200 people who did not have cancer. And in this study, they found that their specificity rate was about 99.5%, which means in the group that did not have cancer, the Galleri test correctly tested negative. And then in the group that did have cancer, the sensitivity rate was only 51%, meaning even though you know a patient has cancer, the Galleri test only tested positive in about half that population. And then in terms of whether the GRAIL test correctly identified the underlying diagnosis, the accuracy rate was about 88%. And so the usefulness of this type of testing really depends on what you expect is the prevalence of the disease in the population. So if sarcoma is 1 in 100,000 or 1 in a million in a population, then even a 99.5% specificity rate is not good enough, right? Because you will miss a 1 in a million cancer, and you will be likely to not detect a 1 in a million cancer. And so I think this test is still needs a little bit of improvement, and has to undergo more testing to really help us learn how it can be used to help actually benefit patients rather than just giving them a test result. So in sarcoma, a big clinical question is whether or not we should give patients chemotherapy after we remove their primary tumor. So in this recent article published in March of this year, our group at Mass General looked to see if prior clinical trials that looked at adjuvant chemotherapy showed any signal of survival. And so rather than doing a brand new study, we took about 19 clinical trials that have been done in the past. And if you add up all the patients in these 19 trials, they made up about 2,100 patients. And this study did find that adjuvant chemotherapy improved overall survival. The P of 0.002 means this finding was statistically significant. The hazard ratio of 0.8 roughly indicates that adjuvant chemotherapy may have decreased the risk of death from sarcoma by about 20%. However, the decrease in risk was very marginal, as well as the statistics around the benefits of either doxorubicin with or without ifosfamide. And so even the authors of this trial, I'm sorry. So before I go on, these are the 19 trials that they looked at. The line in the middle is the line of equivalency. And so all the studies on the left of this line showed some benefit of chemotherapy. And all the dots on the right of this line actually showed no benefit or even harm of chemotherapy. And you can tell just by eyeballing that, you have a couple more of these studies that were on the left of the line than on the right of the line, which is what contributed to the slight improvement in the overall group of 19 studies put together. So even the authors of this study said that this study only partially supports the benefits of adjuvant chemotherapy in treating localized resectable soft tissue sarcomas. And because there are so many different types of soft tissue sarcomas, the benefit and the risk of treatment with adjuvant chemotherapy still needs to be evaluated on an individual benefit-risk basis. And so that's where ctDNA can potentially be helpful. And so the decision tree in using ctDNA would be if you had a sarcoma that was removed and all the clinical parameters using size and grade and location indicated that the sarcoma had a high risk for recurrence, then the question is, can we use ctDNA to help decide whether or not to use more chemotherapy? So an example would be if the test showed positive detection of ctDNA in the blood after resection of tumor, then you may use this positive test to argue that you can go ahead with chemotherapy versus just observation. And I'm not going to dwell on this because I think Dr. Loong had a much better version of this, but this is a trial that looked at the feasibility of longitudinal ctDNA assessment in patients with leiomyosarcoma. And if you can see here, roughly speaking, these circles, the white circles indicate a negative ctDNA test, meaning there was no ctDNA detected. Black circle indicates ctDNA was detected. Red triangle indicates that a scan does show growth of sarcoma, whereas green or orange suggests that there was either no disease or stable disease. And you can tell from these 4 patients that a red is almost always followed by a black circle, right? In number 26, a red triangle suggested scans show disease progression. Black circle indicated that there was ctDNA then found in the blood. And so this shows a pretty high correlation between actually positively showing ctDNA versus positively showing CAT scans that show disease growing. This is actually a very useful example of using ctDNA. So in this study, we studied a type of sarcoma called GIST, or gastrointestinal stromal tumor, and we compared 2 different GIST active drugs called ripretinib versus sunitinib. Now we already know that in GIST there are specific mutations along the KIT gene that may or may not predict for a response to treatment. And in this situation, the study showed that patients that have a mutation in exons 11 plus 13 or 14 seemed to respond better to sunitinib, and patients with mutations in exons 11 plus 17 or 18 seemed to respond better to ripretinib. And they largely used ctDNA to detect those mutations in blood. And so, in these samples, they found that of the 362 patients being tested, ctDNA was detected in about 77% of these patients. And of these patients, about 213 had KIT mutations detected. And so you can then use ctDNA testing to see if, through just a blood test, you could look to see if there was a mutation in exons 13, 14, 17, or 18, and that would help you decide whether or not you want to treat the patient with either sunitinib or ripretinib. And so this is probably the clearest example of how we can use ctDNA to actually choose the best drug for the patient. So in conclusion, there are various advantages to using ctDNA versus tumor tissue. ctDNA is obviously not invasive. You just need a small sample of blood drawn by phlebotomy. This can be done by a nursing clinic or a visiting nurse at the patient's home. It does not require surgery or a needle biopsy. And you can do real-time monitoring because the test is not invasive. You can repeat this test serially. And if the test results can be returned fast enough, you can make real-time decisions on whether or not to continue the current line of therapy. So just want to acknowledge my clinical team here. And at this point, I think we can open ourselves up to questions.
Yeah, we'll open. So we've got time for a few questions here. I would like to start with the first one, and that was, just what do each of the panelists find as the most promising current research happening in sarcoma for the ctDNA? It may be early days yet, but just what do you see coming down the pipe that interests you most?
I'm happy to jump in here. I think Dr. Choy gave some really great examples of areas of sarcoma care where we really are struggling with the tools we have to know how to help patients make decisions about things like, should you have chemotherapy for a localized soft tissue sarcoma? And so just as Dr. Choy said, I think having circulating tumor DNA tests that may be able to tell us something about when a patient walks through the door um, with much sort of greater precision. Are you likely to benefit from chemotherapy? And then after we've started the chemotherapy, using things like minimal residual disease tests to say, is the chemotherapy working specifically for you? Is it causing the tumor cells to die and making it more likely that you're going to have a good outcome? I totally agree that we have a ways to go in studying this, but I think some of those areas where we currently have uncertainty with the tools we have, that will really give patients a much better likelihood of benefiting from the therapy and not getting exposed to things that are not going to be helpful in their care is really a potential great use of this technology.
I really. Oh, go ahead, Herbert.
I fully agree with what Dr. Schulman said, and I think Dr. Choy quoted a very good example. I think in terms of sarcomas in general, and where there potentially is an application for ctDNA. To begin with, again, a lot of it is still in the investigational or experimental stage. But I would echo what Dr. Choy's mentioned in terms of the type of sarcoma where I think this technology is most mature would be in gastrointestinal stromal tumors or GISTs, which was the example that Dr. Choy used. So certainly there have been clinical trials currently ongoing, really looking at using ctDNA to help us choose which particular treatment is best for patients after they are entered into a study, because you would expect that by treating them with one targeted therapy, it may change the resistant mechanisms, and there are other targeted therapies which may be useful. So I think there are many factors that come into play in seeing whether ctDNA is useful. It depends on what treatments you have. It depends on whether or not that particular type of sarcoma can be readily detectable or detected with ctDNA. And I think some of the questions here that's being posed by our audience is also very relevant because certainly there are situations where it's not just one particular mutation that you could detect in the blood. There are various other genetic alterations which unfortunately ctDNA by itself may not be mature enough right now to help with that detection. So I think all the stars have to align before it's actually useful. But I think we're trying to get there through our experiences in other cancers as well, and as well as in sarcomas.
I think the more we understand which mutation can lead to which outcomes, the more useful ctDNA can become. And so right now we're still at infancy. I think the sarcoma type that has the most understanding of mutation to phenotype is GIST. And so I think in GIST, ctDNAs have become a standard practice for me in my own clinic.
Thank you very much. So this is kind of along those lines, but so current imaging isn't always sensitive or specific enough for detecting small volume disease in sarcoma. How close are we seeing using ctDNA assays to being incorporated into clinical trials? It's kind of like an adjacent test to determine like as a non-invasive marker of treatment response in some of these other diseases as well. I mean, just is already spoken to that, but are there any others that you see that coming down the pike?
I can start with the answer with an answer. I think the real challenge in small volume metastatic disease or small volume relapse for sarcomas is the actual treatment options that we have for this. And so there's actually no data that we've been able to generate showing that treating a metastasis in the earliest possible time point actually leads to better outcomes for our patients. And so, a scan, a clean CAT scan may miss a 1 millimeter metastasis in the lung. And then you can catch that 3 months later with a 7 millimeter lung nodule. And in that situation, we don't know that detecting it earlier is going to do anything better for the patient. So I think that's the main limiting step in terms of if I had a treatment that I knew had better outcomes the sooner we give it, then we would use something like maybe ctDNA or even more frequent scanning in order to be able to screen for that.
Yeah,
Yeah, so go ahead, David. I'm sorry.
I was just going to say, I think the other area where we're really thinking a lot about this are for some of the sort of more common sarcomas that we see in adolescents and young adults, which is really my area of focus, where we're very commonly giving chemotherapy. So these are diseases like osteosarcoma, Ewing sarcoma, rhabdomyosarcoma, and one sort of minimal residual disease question we have is, what does it mean if you have residual circulating tumor DNA after, say, 3 or 4 weeks of therapy? Or what does it mean if you've cleared your circulating tumor DNA at that time? And we're just starting to actually understand the landscape of what circulating tumor DNA is among a population of patients at those time points. And then the next step is really to ask, what does that mean? So are we getting a marker here of how well the chemotherapy is working for a specific patient? And there was a question about sort of how is this being studied? Is it being embedded in clinical trials? And I'm a pediatric oncologist, so I spend a lot of time working with the Children's Oncology Group. And I can tell you that for years now we've been doing sample collection and studying samples from patients who join the Children's Oncology Group trials for this group of diseases, and we're starting to get a much better sense of this. And so what I expect is we're going to start to see a signal that patients who have minimal residual disease after their initial treatment are at higher risk of having their tumors come back. Conversely, you could say if you've cleared, that's a really good thing, and it's good to know. But before we are able to really act on that, it will take another generation of clinical trials where we actually say, okay, if you have residual disease or if you've cleared, we're going to do something different. And Dr. Loong kind of alluded to this in research that's been done in other cancers that are more common. They run studies much faster, but where they've actually done things like removing or adding chemotherapy or changing chemotherapy based on your sort of residual circulating tumor DNA. So that research really is in the works for some of these diseases, but it will take a bit more time.
So kind of a basic science question that I have is what is the average like half-life of circulating tumor DNA? Do we know that? Or, so how long out do you have to test for the minimal, for the ctDNA before or after surgery or after treatment? Does that make sense?
It's on the order of like hours. So
Okay.
We've presented some data, for example, in Ewing sarcoma and osteosarcoma at the ASCO meeting and the CTOS meeting over the last few years, looking at circulating tumor DNA 24 hours after patients start chemotherapy, and then 3 or 4 weeks after patients start chemotherapy. And at 24 hours, those levels are similar. Certainly in some diseases, they actually see them spike because you get some tumor killing from the circulating tumor DNA. The levels go up a little bit, but we think they go down relatively quickly after these treatments. Because they're double-stranded DNA, they are more stable, and you can sort of stabilize them in these specialized blood tubes that we use to collect them. But Dr. Choy and Dr. Loong can correct me if they think differently, but we don't think these sort of strands of DNA themselves persist for like days or weeks. Like the body sort of digests them relatively quickly.
Yeah, I think Dr. Schulman's right, and certainly I think in terms of the other cancers where ctDNA is more readily employed, I mean, we do feel that in situations where it is reflecting or useful. It does reflect the patient's response to treatment. So if there are more tumors in the body, the ctDNA levels would go up. And if there's clearance, in actual fact, it's also an indication of the fact that more of the cancer cells are being killed. So the dynamism of the ctDNA does reflect the overall tumor burden in patients.
So, for patients that are interested in ctDNA and their treatments and everything, so if two questions. First, if a provider recommends ctDNA testing for a pediatric patient, what are the risks and advantages that a parent should be aware of? And then secondly, can you give some tips on how patients should approach their provider in asking about ctDNA testing in their situation?
So I briefly touched upon some of the possible harm of testing, right? So, if the testing was 100% accurate, sensitive, and specific, then that's great. But, the harm is, what if the results do not actually reflect reality? And so for a pediatric patient getting ctDNA tested, a false positive could lead to getting the patient back on treatment or chemotherapy that may be unnecessary, or doing more scans and biopsies that may be unnecessary. So unnecessary treatment and biopsies and scans, unnecessary anxiety, right? There's a psychological impact of testing positive, even if that may not reflect reality. And then your second question on that was, remind me again?
Just, maybe some
How do you talk
guidance
to your
on,
doctor?
yeah.
Yeah. I think a test is only as good as our ability to interpret the results. And so you really want to start with whether or not your oncologist is comfortable interpreting results. And if they say, we can do this test, but I won't know what to do with the results, then that's a good reason not to do the test with that physician.
And so currently, is ctDNA testing done mostly at academic institutions, or do you see it in the community oncology situations, or do you have any ideas on that?
Oh, sorry, go ahead,
Go
Edwin.
ahead. The test is commercially available, so any MD can order it. I do see often patients coming to me for a second opinion from the community with a commercial test being done. But again, often they do the test without really knowing what to do with the results.
So it's best to, if you approach your oncologist about doing the ctDNA test, make sure that they're comfortable with interpreting it, and if they're not, then go to a larger institution maybe for a second opinion on that.
And you should have a plan of what to do, right?
Yeah.
I think just doing it just to see, I think, can lead to trouble. But if you do it with a plan of like, this is what we want to do with the results.
Well, unfortunately, I'll go ahead.
I was just going to say, I really agree with what Dr. Choy just said in kind of the last two answers. I think another thing to keep in mind is many of the commercial tests out there, which are great tests, are comprehensive tests. So they're actually testing for, often 300 to 400 different genes that we see mutated in cancer. And you're testing it on just a big pool of DNA that's floating around in the blood. So you can also get results back that you and your doctor may not have expected. They can certainly pick up germline variants that may be gene mutations that are passed down through families, and they're going to show up on the test report because you're testing all the germline DNA. You can see other things that we haven't really talked about here, but like clonal hematopoiesis, which actually may be mutations completely unrelated to the cancer, but that float around in the body's white blood cells that we also are still only learning about how to deal with. And so there's a variety of other unexpected results that, that may or may not be related to the tumor. That I think you also want to make sure your doctor feels comfortable thinking through with you, and just being aware that you may learn these other things. Yeah.
Okay, and with that, we'll have to wrap up our session for today. Thank you all for taking the time to be with us and sharing your expertise and experiences. We appreciate all that you do for the sarcoma community. As a reminder, today's session was recorded, and we will link to, and the link will be posted to SFA's website within the next few days at curesarcoma.org. This now concludes the discussion. Thank you very much.
Thank you.